Okay, hi everyone. Hopefully you can hear me speaking. So we'll get started. So this week, welcome to week 3, I believe. Today we're going to be talking about GIT embryology and the anterior abdominal wall. So let's start off with embryology. Sometimes embryology can be a bit overwhelming, and especially at the beginning, there's a lot of new words. I found like there's not really always a strong foundation for embryology. So you're talking about ectoderm, endoderm, no idea what that is, you just know it exists. So it's always hard the first time round, but I really do promise that will get better the more you revisit it. And if you ever need any resources for embryology, there's a guy on YouTube called Dr. Minas. He's really good. Like highly recommend him. He has videos for like the liver, the pancreas, the foregut, midgut, hindgut, everything you could possibly want, and also for other systems. So really recommend. Maybe a little bit too much detail for what we need to know, but he goes from the very basics. So really highly recommend watching him. So we're going to start from the very basics today. So we have, so we're going to talk about the gastrointestinal system, and first we're going to mention the Trilamina Disk. So hopefully you've already seen this before and it's not like a really new word for you. But essentially the Trilamina Disk is the 3 different layers of an embryo. And this, it sort of sections off into 3 different layers after the 3rd week of gastrulation. So just to revisit what gastrulation is, it's a process from which it changes from a blastula, which is just 1 cell, to multiple layers of cells. Okay, and in this case, we get 3 layers. We get the ectoderm, mesoderm, and the endoderm. All right, and so essentially everything in the body really comes from these layers. So you can see in this picture here on the right, we have the endoderm, we have the mesoderm, and we have the ectoderm here. Okay, and everything comes from them. So in the context of the GIT system, the endoderm, which is the inside layer, contributes to the epithelium of the GIT and the parenchyma. So parenchyma is just a fancy word for the actual organ tissue itself. And endoderm is the most inner layer. So it's this yellow part here. You can think of this as like the inside. The mesoderm is the middle, and the ectoderm is sort of like the outside covering. So in the GIT, the visceral mesoderm gives rise to stroma, connective tissue, and the muscles of the GIT. How I kind of like to think about it is just M for middle, M for mesoderm, and M for muscles as well. That's an easy way of remembering it. And by the way, stroma is just another fancy word for a specific type of connective tissue. That's all it is. And then the ectoderm, which is the outside part of the disc, contributes to the neural tissue, so all the nerves, as well as the skin of the abdomen. It also does specifically give rise to the epithelium of the hindgut, but that's not really that important, at least I don't think, so you can ignore that aspect. So this slide is just a summary of everything you need to know here. It's probably not that high yield, but it is good to know that it exists, and that's what forms, yeah, that's pretty easy. And just another way of remembering the layers, so endoderm is on the inside. You can think of endothelium of like blood vessels, and you can remember that's the inner layer, M for middle. And ectoderm, ecto kind of sounds like exo, and you know, like exoskeletons are a thing that go on the outside. That's just a neat way of remembering what is actually like the layers, what order they are. But yeah, it's not that high yield, but it's just good to have an understanding. So with the GIT, essentially, you can think about even in the adult human, that the GIT is essentially one really long tube, and you're sort of like a donut. You have like a little hole in the middle. And so you arise like that with your embryology as well. So the GIT tract mainly arises from something we call the primitive gut tube. So I'll show you in this next one here. You can see that this is the gut tube here. Yeah, it's just one long gut tube. It doesn't really look like a tube, but I promise it is a tube. And because it's one really long tube, and you can probably think in the GIT, I mean, your esophagus is going to be a little bit different to your stomach, which is different to your intestine, which is different to your rectum. To sort of deal for this really big part of the human body, we actually split it up into 3 regions. So the foregut, the midgut, and the hindgut, okay? And each of them form a bit differently to each other, okay? This is definitely something that is high yield. If in anything in embryology, you'd probably be asked, like, what is foregut, midgut, hindgut? So please do know this really well. So foregut, it starts sort of at the top, at the cranial end. So it goes from your esophagus, includes your stomach, and then the first part of the duodenum, and specifically it's the ampulla of Vater. And that's pretty important to know. Then the midgut, again, M for middle, is between your ampulla ovata and the duodenum to 2/3 into the transverse colon. So that includes like the hepatic flexure, if you know what I mean when I say that. And then the hindgut is just the rest of it all the way to the rectum. Okay, this is definitely really, really important to know. Now with the arterial supply here, I'll just make sure I'm actually presenting. Hopefully that should be better. Sorry, guys. So with the foregut, it's really important to know the arterial supply for the foregut, midgut, and hindgut. Essentially, what this means, we'll be coming back to this next week anyway when we talk a bit more in detail about the neurovasculature. But you think about how the esophagus, the stomach, and the first part of the duodenum, they all are supplied arterially from the celiac trunk, which is just a branch of the abdominal aorta. The midgut, so all the organs in the midgut, so for example, like the jejunum, the ileum, the ascending colon, they're all supplied by branches of the SMA, which is just the superior mesenteric artery. And then the hindgut, so essentially your descending colon and your rectum, they're all supplied by the IMA, the inferior mesenteric artery. Okay, the numbers and letters and brackets, that's just the vertebral level. You'll notice that the celiac trunk and SMA are very close, T12, that goes to L1. And then there's a bit of a gap between the SMA and IMA. There's L1 to L3, so it skips L2. A way to kind of remember that, I mean, it made sense to me. I don't know if it'll make sense to anyone else. But essentially you have like the large intestine in between the midgut and the hindgut, because it's 2/3 of the way into the transverse colon. And so large intestine, meaning there's a large gap. So there's a bit of a larger gap between the vertebral levels of these arteries. Now, it's also really quite important to note that as part of your gut tube, your trachea and lungs also arise from the foregut. So they actually start out as a gut tube, but they just separate on a little bit later. And if this actually fails to happen, you can have connections and malformations between your esophagus, the trachea and the lungs. Which isn't very good because you don't want food going down into your lungs or air going down into your esophagus. That's interesting. Next slide. So the next section is just going to be like a super duper brief overview of, I guess, all of GIT embryology. So as I was saying earlier, the gut tube is literally just a tube. You can kind of see it here, and it's split up into 3 sections. So we have the foregut here, which is closer to the cranial end or the head end. I guess cranial relates to the word cranium, which is like the skull. Then we have the midgut, which is in the middle, and then we have the hindgut. That's also referred to as the caudal end. These are words that you really do need to start using in embryology and anatomy in general. And hindgut is just the end. That will be your rectum, for example. So yes. That's the tube here, and what happens is that they actually start folding in towards each other. So the cranial end and the caudal end are sort of doing a bit of yoga, I guess, and they're starting to fold up towards each other. So it ends up looking a bit more like this image here. And you can kind of see like it starts looking a bit more like a classical embryo that you see with the head here. You have your heart, your gut, and your hindgut. So it starts looking a bit more familiar. Now, important here with the midgut, you can see that we have here this other section here that's actually continuous with the midgut. So you can see here, we have the midgut here, dotted line, and this has the yolk sac, okay? And it's just, for now, just know that it's continuous. The yolk sac, if you're confused about what that is, you'll learn a bit more about this in Repro next semester. You actually go over like a bit more embryology. It just makes a bit more sense. But for now, the yolk sac, all you have to know is that it provides a bit of nutrition and gas exchange between the embryo and the mother during development. And it's a site of hematopoiesis. So it sort of takes over before there's like a placenta involved. Okay, so during and after this craniocaudal folding, the foregut, the midgut, and the hindgut are all developing. I'm going to skip over that just for now, and we'll come back to each of the sections, how they develop. So pretend like everything is developing, and we'll come back to it. But for now, what happens is after everything has been formed, all the organs are in their correct place, everything is looking good, you can imagine that because there's a lot of growing happening, a lot of the endoderm can actually occlude the lumen of the gut tube. And so essentially it's not a hole, it's like a solid object. And you know, in your gut tube, you need things to move through. So sometimes and this process to get rid of this occlusion is called recanilization. And recanilization doesn't happen, you get stenosis. through which food and other things can actually pass through. And that's important to sort of just know about. It's not that high yield, but yeah, you do have to know about it. Now, lastly, I'm just going to briefly talk about different mesenteries and what ligaments they become. So I remember the first time I ever watched a GIT embryology lecture, I was so confused by what they meant by the word mesentery. So essentially, don't get too hung up about it, but the mesentery is essentially a double fold of peritoneum that attaches organs to the posterior abdominal wall. And so its main function is that it literally holds some of the organs in place. It doesn't hold all the organs in place because some of the organs, like the aorta, are literally just embedded already into the posterior wall, whereas some of them, like the stomach, you can imagine if there was nothing holding it in place there, it'd just be, I guess, floating around in the abdomen, and we really can't have that, okay? So mesentery, double fold of peritoneum that attaches the organs to the posterior abdominal wall. It also has some other functions, like it has some neurovasculature, some fat, but that's sort of a secondary function. So in the mesentery, we talk about, in embryology, we talk about these very specific mesenteries. So dorsal mesentery of the stomach, ventral mesentery of the stomach, and another subsection of the ventral mesentery, which is the mesentery between the stomach and the liver. And in the adult, these mesenteries change a little bit in their position, okay? And just to differentiate between the embryology and the adult mature form, we just rename it to a different name, essentially. So the dorsal mesentery becomes what we'll later call the greater omentum. The ventral mesentery becomes a falciform ligament, and this specific subsection of the ventral mesentery between the stomach and liver becomes a lesser omentum. Don't worry if you don't know what the greater and lesser omentum is just yet. I'll briefly explain it. So this is just a diagram. So you'll see in my slides, I put a lot of diagrams in, and that's because embryology is a very visual thing. You will not get through by just reading about it. You really have to have either videos or some sort of diagram to really help you. So here, I'm just going to talk about the mesenteries again. So this first picture in the top right, that's the embryological form, okay, that all your organs start off with. So this pink thing here is the liver, this yellow thing is the stomach, and this little round red thing is the aorta, all right? And in between, you can see already, you have some connective tissue between these organs, okay? And so these are the mesenteries, okay? In this diagram, they specifically point out the ventral mesogastrium and dorsal mesogastrium. Mesogastrium and mesentery are basically the same thing. This is just specifying that the stomach is involved. So in this presentation and in my slides, I use them pretty interchangeably, okay? Now this falciform ligament, which in the grown adult connects the liver to the anterior abdominal wall. In this diagram, they put it a falciform ligament, but you might also see it being referred to as just ventral mesentery, okay? That's what it should actually be. So this diagram is a little bit wrong in that this should be actually a ventral mesentery. So you can see here, this is the intermediate form between the embryological and the mature form, and then we have the mature form. And so you can see here, in this kind of wrong diagram, the falciform ligament has actually stayed the same name. But if we look at the ventral mesogastrium between the liver and the stomach, you can see the ventral mesogastrium, which is here, has just changed name to the hepatogastric ligament, which is a ligament that's found in the lesser omentum. Okay, and the same thing here for the dorsal mesogastrium. We have it here. Okay, and then if we look, that's connecting the stomach, and it actually will be connecting to the spleen. So we see here, it just changed name to the gastrolienal ligament. It's also called the gastrosplenic ligament. So what defines whether mesentery is ventral or dorsal? Having a look at this diagram, this is the ventral side, so the more like anterior side of the person where the stomach is, and dorsal side, that's where the back is. So you can see the stomach sort of divides it in half. So everything in front on the ventral side of the stomach is ventral mesogastrium. Everything behind it is dorsal. So this diagram is also good to discuss what happens to the liver and how the organs end up going from midline, sort of here, to the mature form where you have the liver on the left, the liver on the right and the spleen on the left. Sorry, I sometimes get confused. So see here, the liver sort of drives all the positioning in the abdomen. So you can see here, it's actually moved over to the left, and because it's connected to the stomach and the spleen and the pancreas actually develop in the dorsal mesogastrium, it shifts over all the other organs with it. It brings them over, okay? So that's why the stomach starts shifting a little bit, and the spleen, because of how the liver is moving, it wants to move towards the left, okay? So that's why we end up with the spleen here. Okay, so that's kind of important to know as well. It's not that high yield, but it makes sense as to why everything is actually placed where it is. And another thing I'll mention in this diagram that's also pretty good is the left and right vagus nerve. So you see here now developing embryological stomach, we have the right vagus nerve on the right and the left vagus nerve on the left of the stomach. If we look at the mature form, the left vagus nerve has moved to the ventral side, or the anterior side of the stomach, and the right has moved posteriorly on the dorsal side. And that gives you a clue as to how that has happened, because you can see the stomach is actually rotating 90 degrees and it brings along the vagus nerves with it. Okay, so you can see how the right vagus nerve, which was here, has moved posteriorly. So it's moving about 90 degrees clockwise. And that actually could come up in the exam to know that the stomach moves 90 degrees clockwise. And the vagus nerves actually give you a little bit of a hint with that. So if you can remember why the vagus nerves, why the right one is posterior, you can remember it actually does move 90 degrees. So yeah, it's a really good diagram. So this is just another slightly more complicated diagram on the right, showing again the movement of all these organs in the mesenteries. These diagrams are actually really good, so I recommend just going through in your own time, just having a look through them. They're really, really nice and they make a lot of sense. Maybe a bit too complex, so just take it easy and just make sure you're following all the arrows correctly, because I definitely wasn't when I first looked at these. So these pictures here, I'm just demonstrating for those who may not know what the different ligaments are. So Fasciflon Ligament connects the liver to the anterior abdominal wall, okay? And as you can see, this comes from our ventral mesentery. The greater omentum is this big yellow blob here. It's pretty cool, it's pretty big. And that also comes from, sorry, not also, it comes from the dorsal mesentery, okay? And then lastly, we have the lesser omentum, which if you see in this picture here, is the smaller one on this side here. That's what it is. Don't worry too much about it. We'll be coming back to it next week when we actually talk about lesser and greater omentum more in depth. Okay, so it's coming. Just know from which mesentery they arrive from. That is important. So the next section I'm going to go through is Volga Embryology. I'm trying to keep the writing as simple as possible because it gets too confusing otherwise. So really pay attention to all the diagrams. They're very good. So please have a look. So first of all, we'll talk about the esophagus. So esophagus is really easy. It's already a tube, the gut tube. So if we see this green bit, this is the primitive gut tube. The esophagus just continues as part of the gut tube. There's nothing fancy. The only thing is that you can see the lung buds, which are your future trachea and your lungs, your respiratory tract, that comes off the same tube. So you can see how something can go wrong here. You can actually look up on Google. You can Google different malformations. It's actually pretty interesting to look at just how many ways this can go wrong. And then the liver is also pretty easy. So again, we're talking about the foregut, remember, which is the esophagus to the first part of the duodenum with the ampulla ovata. So see here, in this picture on the right, we have essentially the foregut. This little dilated bit, this is your future stomach. Okay, so it does dilate a little bit. These little yellow buds here, that will be your pancreas. It's into at the moment, and I'll explain how it becomes one organ. Hopefully it becomes one organ. Then we have the gallbladder here in green, and we have the liver here in grey. Essentially, the liver just starts branching out from the ventral foregut endoderm. Okay, that's legitimately all you need to know. It just branches out from the stomach, essentially. Or it's not really correct to say a stomach, the foregut. And the gallbladder just grows along with it, essentially. So pancreas is a little bit more exciting, and we care about the pancreas a little bit more because it more commonly goes wrong here. And you could be asked on the exam about an annular pancreas, which is an embryological defect. So the pancreas, as you can hopefully see in this image here, so we have the growing liver, it's growing out, that's all good. We have the ventral pancreas and the dorsal pancreas. Okay, and hopefully you can see how in this image here, the ventral pancreas has actually moved all the way back to meet the dorsal pancreas. Okay, they start as two separate things. and the ventral one has to travel to meet the dorsal one. Okay, and then what happens is essentially they will fuse together to make one pancreatic bud. Okay, and all the tracts here also fuse, and that's why the pancreas can actually have, we'll be covering this a bit later, but it has like a main tract and also has an accessory pancreatic duct. Should we say duct? I don't know why I was saying tract, ducts. And that's why you can have a bit of difference between people anatomically because of this formation. It's not always clear where it might fuse and which ducts might fuse with each other. So that's how you actually get a bit of difference there between adults. So what happens sometimes is that this goes wrong and we get something called an annular pancreas. You can see here, again, just with these diagrams, make sure you're following correctly, A, B, C, D, E. So we have here the ventral bud and the dorsal bud. And you can see, oh, sorry, this is correct. Sorry, actually looking at this picture. We have the ventral bud and the dorsal bud. And you can see here how instead of the ventral bud just going around behind the duodenum to meet the rest of the dorsal bud, it's sort of split in half. And so half of it has gone behind and half of it has gone in front to fuse with the rest of the pancreas. And so you essentially end up constricting your duodenum. And that's what's called an annular pancreas. Essentially, you'll see it in babies who can't really, they don't want to feed. They might be vomiting and they're essentially just not eating and they might be malnourished. So if you have a baby come in with that, you're probably thinking, baby is an annular pancreas. All right, so pretty interesting. Continuing on with the stomach. So as in the previous picture here, I was talking about the stomach essentially just dilates a little bit from the actual main gut tube here. So you're dilating a little bit. But what is important, as we've already talked about before, when we talked about the mesentery diagram, your stomach rotates 90 degrees clockwise. And that's why the vagus nerve, the right one becomes posterior and the left one becomes ventral, because it's rotating around 90 degrees and bringing with it the vagus nerves. That's really all you need to know about the stomach. But if you have a look here, I'll see if okay, here we go. This is a better picture. So again, it's just dilated out. This pink thing is just demonstrating the rotation. So you can see how it starts off this way and then ends up at a 90-degree angle in the mature form. And it rotates around its longitudinal axis, 90 degrees. Also rotates down its ventral dorsal axis. And essentially all it means is that this bit here, the greater curvature of the stomach, just ends up being a little bit lower. So you can see how it's sort of going down and out. Now, if you watch Dr. Minaj, he has some very good ways of remembering this. And he calls it the Nicki Minaj maneuver. And because essentially like this greater curvature, you know, it kind of looks like a butt. And then it just goes out and down. And so she's kind of sitting down. So that's how you can kind of remember. That's how this ventral dorsal axis rotation gives you the greater curvature. If you have a greater curvature, probably means you have a lesser curvature, which is on the other side. So that's how these curvatures form. Probably not the most important to remember, but it is like good to just know about it. Don't worry if you don't really know what a lesser and greater curvature is at the moment. We'll be coming back to that next, hopefully. So moving on to the midgut. So we're mainly going to be talking about the jejunum and the ileum. The lower duodenum just arises, again, just from that dilation, essentially. Nothing really exciting happens with it. So with the midgut, I'm not going to talk through all this writing. You can review that in your own time. I'll be talking through this diagram. So the diagram on the left is probably my most favorite diagram for embryology. So essentially, again, remember the midgut is the section from the ampulla, vata, and the duodenum to the 2/3 of the transverse colon. Okay, so essentially it's the bulk of your jejunum, ileum, and a little bit of your large intestine. So you can see here we have the midgut. Now remember, back in the very first few slides, I said that the midgut is continuous with the yolk sac. And so what happens is that the midgut, this tube, starts elongating really rapidly. And it gets so big that it can't all stay inside the gut tube. It has to go somewhere. So it sort of forms this U-shaped loop. And this U-shaped loop herniates outside into the yolk sac. And so essentially this U-shaped loop that herniates through the yolk sac and through the umbilicus forms a cranial part, which is this purple part, and a caudal part, which is this green part, okay? So essentially what happens then is that whilst it's outside, and it's outside of the gut tube, okay, it's herniating through the umbilicus and into the yolk sac, it starts to loop around. So in the second one, oh, actually no, it's still in the first one. You can see here it has a big arrow. Your intestine will loop around so that the purple part becomes the lower part and the green part becomes the top part. So you can see how they've just switched position, okay? And this is really important to know that it rotated 90 degrees counterclockwise when it's herniated. That's really important to remember. I think the next slide has just a summary of the rotation, so if you need to memorize it. And it rotates around the superior mesenteric artery. And you should remember again that I mentioned before that the superior mesenteric artery, SMA, is the artery supplying the midgut. So that's really, really important to know that it rotates around the SMA. You can very well be asked that in the exam. That's really, really high yield. So whilst it's rotated, okay, and it's still outside, you have this jejunal-ileal loop. So the purple part is what becomes your jejunum and ileum, and the green part is what becomes your colon, your large intestine. So you can kind of see it in the final position, picture number 4. The green part is just your large colon, and the purple part is just my colon. So you can notice here that it's starting to loop together. And so it's just looping together. And that's why your small bowel ends up being really coiled, whereas your large colon isn't as coiled. That's sort of important to know. And so after it's done this coiling and it's already rotated by 90 degrees, it comes back inside into the midgut, where it then completes another 180 degrees counterclockwise rotation. Okay, this sounds really complex. I promise it's not. All that happens is you can follow the cecum with the little appendix turning out here. If it rotates 180 degrees, you can see how in the final form it's gone from sort of this top right position into this sort of lower right position. And that's why your appendix is usually found in the right iliac fossa, because of this 180 degree rotation counterclockwise whilst it's back inside the embryo. Yeah, so that's why it's there. And that's also why you can sometimes get appendixes that actually are stuck up in different places. So if it doesn't complete this 180 degree rotation, you might find that your appendix is actually in your right upper quadrant instead of your right iliac fossa. Okay, and again, that even might be an exam question. They might ask, like, why did the appendix end up in the right upper quadrant and not in the right iliac fossa? So yeah, that's essentially it. So again, key points to know. Midgut herniates outside through the yolk sac, rotates 90 degrees clockwise around the superior mesenteric artery. After that, it returns back inside and does another counterclockwise rotation 180 degrees. And this was both counterclockwise. Oh yeah, that was clockwise, and then the second one is counterclockwise. All right, so that is really important to know. And this is just also another really nice diagram that sort of shows this rotation. So this is just a bit of a summary as to the rotation. If you need to learn it and not understand it, better to actually understand it. But yeah, so the 270 degrees, that's me combining 180 plus 90. So it does a total 270 degree rotation. So this is actually wrong. It should be 180 degrees clockwise, counterclockwise, to do a whole like 180 degree turn. Yeah, so sometimes things go wrong in the midgut, and you have something called an amphilocelli and gastroschisis. I have no idea if I'm saying it right, so I'm going to avoid trying to say these names because I'm terrible at it. So essentially, remember, the midgut is herniating outside the gut tube at some point, and sometimes that contents fails to return inside the abdomen before the child is born. So essentially, you might have a baby that's born with all of its like intestines on the outside of its body, which is pretty crazy. And so there's two types. There's omphalocele and there's gastroschisis. They're both a little bit different, and this has been an exam question before, so it is important to know the difference. So omphalocele is essentially when the contents actually just fail to return back. So it's herniated, and then it didn't return back. So it just stayed outside the whole time. And so this contents will actually be covered by an amniotic membrane and the peritoneum, and it forms this hernial sac. Okay, that's really, really important. If you don't understand anything, just remember it's covered by a sac. All right, really, really super important. Now, gastroschisis, on the other hand, the intestines might have retreated back inside after it's herniated, but it's the actual wall, the anterior abdominal wall, that has either failed to close properly or just didn't form properly, or there might just be weakness in the wall. And so the contents herniates through the wall after it's already gone back inside. So in terms of the intestines, everything has gone normal. Okay, it's just the wall itself that has a defect in it that makes the intestines spill out onto the outside. Okay, and that's why the viscera, the intestines on the outside, are not covered by any sac or peritoneum, because it's just our normal intestines that are herniating. Just be careful with this image. For some reason, they decided omphalocele is on the left, but this is actually gastroschisis. Yeah, it's just a little bit, it doesn't match up with the title, so just be careful of that. We also have something called Meckel's diverticulum. So it's another common defect that can be found. So essentially, Meckel's diverticulum, if we go back to this picture here, you can see here when we have this U-shaped loop, there's a little bit on the end here that sort of sticks out. It's called the vitelline duct. And usually that vitelline duct then just disintegrates. You can see here it's still present, and then by the time it's inside, there's no vitelline duct around. It's just disintegrated. Sometimes this fails to happen, and you get left over with just a little protrusion here, and we just call that Meckel's diverticulum. Often it's actually asymptomatic. It doesn't really tend to bother people, but sometimes you can imagine it gets a little bit stuck, because it's just in the way. So sometimes people present with painless hematochezia. So hematochezia is just blood in your stools, and obstruction, because your stool actually can't get through. And this really is not very high yield, but Meckel's diverticulum has something called the rule of twos. I've actually been quizzed on this year, third year, so may as well learn this. So rule of twos, Meckel's diverticulum is about 2 inches long and 2 feet proximal to the ileocecal valve and affects 2% of the population, which is pretty neat. The one thing here important to remember, it's proximal to the ileocecal valve. Please remember that, very, very important. There has been an exam question sort of talking about the location of the Meckel's diverticulum. So remember, it's near the ileocecal valve. Now we move on to Hindgut Embryology. That's probably the easiest embryology. It's actually pretty, yeah, it's pretty simple. It's my favorite because it's easy. So essentially, remember the hindgut is just the last bit of your gut tube. So essentially, the terminal part is called the cloaca, which is essentially a fancy word for meaning that the pee and the poo came from the same hole. So I think some animals like birds have a cloaca, they just do it from the same end. And so whilst you're developing, for a little bit of a period of time, there's a bit of a cloaca, okay? So we'll skip to this image here. This is a really good one. So essentially here, just to be orientated, the green bits are the lumen. So this is your actual gut tube, and this will be your future bladder, and you have a cloaca. So you can see how the future pee hole, the future poo hole are in the same sort of area. Okay, they're in the same hole. This blue part, this is just tissue. So just get orientated with that. So first of all, we have something called a urorectal septum, which kind of makes sense. It's dividing the urogenital tract from the rectum, essentially. Okay, so it divides the pee hole from the poo hole. And so what happens, essentially, this urorectal septum just continues to grow down until it fully separates the rectum from the urogenital tract. That's really important. Urorectal septum is essentially the thing that drives the hindgut formation. Now, please don't get too confused with this diagram here that says the allantois. You'll learn more about this next semester, so don't worry too much about it. But essentially, your allantois in embryology is essentially like a hollow sac-like structure filled with clear fluid that forms part of like the the embryo essentially. And it helps the embryo exchange gas and liquid waste. And yeah, essentially it's kind of instead of like a placenta at some stage. It just takes care of gas exchange. But the allantois will then become the urachus. So the urachus is just a duct between the bladder and the yolk sac. So if you get too confused with that, it's not really correct to say that allantois will become your future urogenital tract, but it kind of does. So you can think about it like that. It's not technically speaking fully correct to say that, but for understanding purposes, you can think about it like that. That's why you end up with a separate urogenital tract and an anorectal canal. Sometimes that goes wrong and you get something called an inferior anus, and where essentially you just don't have an anus, you have a rectoanal canal with no opening, because maybe the tissue didn't disintegrate. But because we live in the 21st century, which is a great time to be alive, we can just make an anus for these people. So yeah, and sometimes this urorectal symptom goes a bit berserk. So you can still have connections between your urogenital tract and your anorectal canal, and that can cause a few problems, but we can generally fix that. So next bit, I'm just going to talk about what an intraperitoneal and a retroperitoneal organ is. I remember being a bit confused about this earlier, but it's actually not that bad. So intraperitoneal organs are those that are covered by peritoneum on both the anterior and posterior surfaces, whereas a retroperitoneal organ is only covered by peritoneum.
Attention please, Medical Adult, Ward A, Urology, Medical Adult, Ward A, Urology.
Okay, sorry about that. As I was saying, retroperitoneal organs are covered by peritoneum only on their anterior surface. Okay, so just bear with me, I'll just go back and find the other slide that had the diagram. Okay, see here, actually our mesentery slide, I know you're obviously a bit by now. But here, you can see the stomach, for example, is covered. So this yellow bit here, this is your peritoneum. Okay, everything outside is not peritoneum. And you can see how your stomach is sitting literally inside the peritoneum. Okay, so meaning it's an intraperitoneal organ inside the peritoneum. Whereas if we have a look at our aorta, and it's probably clear in this picture, you can see how it's not sitting inside the peritoneum, it's sitting outside the peritoneum. Okay, that's why it's called a retroperitoneal organ, but its anterior surface is still covered by peritoneum. It's just the posterior, it's not fully enveloped by the peritoneum. Now the pancreas is a little bit interesting because you can see in this intermediate form, it starts out intraperitoneal, okay, covers inside the peritoneal sac, and then it sort of moves outside. So you can see there's a little bit still covered anteriorly and posteriorly, but most of it is still sitting outside. And that's what we call secondary retroperitoneal, because it started off inside, and then because of how all these organs have shifted around, which you should know now, is sitting outside the peritoneum. That's what we mean by intra versus retro versus secondarily retroperitoneal. Okay, and it's also important to note that the intraperitoneal organs are suspended by a mesentery, okay, whilst the retroperitoneal organs are not suspended by mesentery because they're literally just embedded into the posterior wall. Whereas the stomach, for example, is not embedded into the posterior abdominal wall. It needs something to attach there so it doesn't float around. That's why we have a mesentery. Sometimes it's a sneaky way of, in exams, to ask, is an organ intra or retroperitoneal, by asking which of the following organs have a mesentery. And you have to not freak out, and you just have to realize, okay, mesentery means intraperitoneal. So all the intraperitoneal organs, you can just choose that one to answer that question. So yeah. This is a list of organs. I'm not going to talk through this. Just go off in your own time. Try and remember it. There's a good little like mnemonic here on the side called tadpucker. It's good for remembering what is retroperitoneal. Pretty useful. Just go through that in your own time. And I think we did have a question in the exam about intraperitoneal. I might be making this up, but I do remember, I think, having one. So yeah, it is important. And this is, I think, the last slide of embryology, yay. And so, as I said earlier, remember that your lumen is occluded because it's growing really, really fast, and we need the hole. So essentially your cells undergo apoptosis, and sometimes that doesn't happen. Okay, so we get stenosis. A very common type of stenosis is called pyloric stenosis. This is a bit of a buzzword on the exam. Pyloric stenosis will cause projectile vomiting because it's literally nothing can go through and your stomach just rejects it, and they literally projectile vomit. And also malnutrition because you're not absorbing anything. So this is obviously in very young babies. You're not going to get an adult with an embryological cause of pyloric stenosis. Yeah, so that's important. And in this picture here, as I was talking about earlier with the esophagus and the respiratory tract, so this is how it normally should be. It splits off. Here you can see different combinations of really whack esophaguses and respiratory tracts, all of which are not very good because here you can't eat anything, at least you can breathe. Here, I don't even know what's going on. Yeah, it's not very good. So that's what can happen, for example. Okay, yay, we've made it to anatomy. So we're going to be covering the anterior abdominal wall. So this is just some surface anatomy. I really highly recommend you to get really, really familiar with all the names of the surface anatomy. So you can see here on the right, we have a bit of a simpler image where we've just divided the abdomen into 4 quadrants. The green is right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. That's also pretty helpful, but it's even better in this 9 quadrant model. Okay, so you'll use both, to be honest, especially in third year. You're like, oh, right upper quadrant pain, or maybe you go right iliac fossa pain. That's a buzzword for appendicitis. So yeah, use both. But here, I know there's a lot of new words. So umbilical region, it's around your umbilicus, which is the fancy name for belly button, essentially. Then we have right lumbar and left lumbar. They can also be called the flanks. So just watch out for that. Right iliac region makes sense why it's the iliacs are there. It can also be called the right iliac fossa, which is what I've heard most often, and same with left iliac fossa. Then we have here the hypochondriac regions. Always a bit like, I couldn't remember which one was a hypochondriac. I used to get confused between this and the hypogastric. Hypochondriac, you should know, if you do know this, is actually someone who's really scared about their health and is always really worried about it. So a hypochondriac will present to the ED complaining of this, and that when everything is normal. And so hypochondriacs tend to be more like anxious people. And so you can think when you're anxious, you're breathing really fast. And since you're breathing fast, it's near your lungs. So that's how I remember the hypochondriac region is near the lungs. I don't know if this helps anyone, but hopefully it does. Then the hypogastric region. So you have the umbilical region. So I kind of pretend that's called the gastric region. Hypo means low, so it's below the gastric region. And then the epigastric, just have to know that. Yep, so really get familiar with it. Now I'm putting this slide in now. We'll definitely be revisiting this quite often, probably in every single presentation. Best to get sort of looking at this as soon as possible, to be honest. The earlier you know this, better you'll be. But essentially why we have all these different quadrants, so 4 quadrant and the 9 quadrants, is essentially like if someone presents with pain in the umbilical region, we can sort of deduce what that actually could be. So you can see here, let's say, okay, early appendicitis, that's actually quite common. They start presenting with umbilical pain that shifts to the right iliac fossa, and you have to know that's essentially a buzzword for appendicitis. So start getting familiar with it now. For today, I'm just going to talk about, I guess, the inferior abdominal wall. So we're going to talk a little bit about, firstly, the surface anatomy here. So you can see on this guy here, we have a few lines, and these lines are quite important to know. So we have the linea alba, which is just a central line that sort of divides the abdomen in half. Okay, so remember it's the linea alba. Then we have the linea semilunaris, which is just, I guess, on the side of the six-pack. And you have 2 of them. You have one on this side, okay? Semilunaris, semicircle, kind of looks like a semicircle, you know. So yeah, it's kind of self-explanatory. And lunaris kind of looks like a moon as well. So another way of remembering it. Inguinal ligament, you should remember from first year that, yeah, there's an inguinal ligament there and you have the inguinal crease. Then we have this line here, which is really quite important. It's called the arcuate line. It's also called the semicircular line of Douglas, but I think arcuate is the most common name for it. Essentially, your inner layers, so the layers above the arcuate line, are going to be looking a little bit different to the layers below the arcuate line. So what I mean is essentially this. So you can see in this picture, this is looking sort of like an axial view, I guess. This bit here is just the outside part, so like the skin. And this here we have where we have the medial umbilical ligament. That's sort of the most interior side. Okay, so you can see here, this part is above the arcuate line, and this part is below the arcuate line. Okay, so you can straight up see that there is a little bit of a difference between them. So I'll just go through the composition on this slide here if you need it written down. So you can see here, we start off with the skin. So this is above the arcuate line. So we start off, actually, wait, that's not above the arcuate line. I just realized. I think this one's actually above the arcuate. Why is it upside down? Never mind. So I think the bottom one is actually above the arcuate line. That's a bit annoying. That's fine. So we have the skin here. Okay. Then we have something called campus fascia, which is this fatty bit here. And then we have another layer that's called scarpus fascia. It's like a little bit of a membrane. Then we have the rectus sheath, okay, which is the aponeurosis of the external and internal oblique. Then we have the muscle, the rectus abdominis. Okay, so that's the abs. Then we have another rectus sheath, okay, but this time it's the aponeurosis of the internal oblique and the transversus abdominis. Then we have the transversalis fascia here, and then the parietal peritoneum, which is different. You can see here, this is below the arcuate line. You can see how the rectus sheath of these muscles, the aponeurosis of the external oblique, the internal oblique, and the transversus abdominis is all just in front of the rectus abdominis. It's not behind. Okay, that's the main difference. Honestly, they keep laboring this point. I don't think it's too high yield, but I don't know, maybe your year is the unlucky year to get the exam question. So hopefully that made sense. Just go through it. I would say I used to get the order of campus and scarpus. I couldn't remember which one came first. I came up with thinking about going camping and you arrive and the camp is called Camp Scarpa. So that just makes sense to me that campus comes first. Again, I don't know if that helps, but it helped me. So just remember Camp Scarpus is the camping ground that you like to go to. So this just talks about the muscles of the inferior abdominal wall. I'm not going to go through this because I think it's pretty easy. You should be experts at muscles by now. I would say probably important to know the directions of the fibers. So know that the external oblique is inferomedial, internal is inferolateral. Yeah, I don't think you need to know innervation of vasculature, but if you're really going for it, you're welcome to. So this is just the diagram of where the muscles are. So have a look at this in your own time if you can. So I'm going to talk about the umbilical fold. So essentially, in this diagram here on the right, you're looking at it as if you are an intestine looking at the front of the abdomen. Okay, so this is just like, I guess, behind all that fascia and muscle and skin we've just talked about. So we have these folds. And these folds are created because they used to have an embryological sort of function, and not all of them have a function now. They're just these folds of peritoneum. So we have the median umbilical fold, we have the medial, and we have two of them, and then the lateral umbilical fold. So the median fold used to be the fetal urachus, which essentially connected the fetal bladder to the umbilicus and provided a route for urine to drain. It's not functional in the adults, so it's just, obliterated, but the fold is still there. The medial used to be the fetal umbilical arteries. Now, the lateral holds the still functional inferior epigastric arteries. And this is very high yield, like very high yield. Like if you take away nothing from the anterior abdominal wall, take away these because this will be asked. There's definitely has been exam questions on it in the past, so please know that. Lateral holds the functional inferior epigastric arteries. Yeah, you don't want to be cutting that because otherwise your patient bleeds to death if you're doing like a surgery and you're doing something around there. So really important. So inguinal canal. So I believe you've seen inguinal canal before last year. You have to learn it again. I'm sorry. It's not very fun. Honestly, you just have to learn it. So we have the interior wall. I'm just going through this in your own time. I don't think there's any use for me to go through it. There is a bit of a mnemonic. It's called MALT. MALT. So the roof is formed by the muscles, the anterior wall is aponeurosis, the floor is the ligaments. Yeah, and the roof is the transversalis fascia. So essentially, like, you can use the mnemonic. Personally, it didn't really help me. I don't know, I didn't find it very useful. It didn't cover everything that I wanted to cover in detail. So I recommend, honestly, just rote learning it at this point. So why we talk about the inguinal canal in the abdomen, we'll get to in a second. It's about hernias, but it's really important to know the difference between the deep ring and the superficial ring. So the deep ring you can see on this picture here, it's this one here. It's found above the midpoint of the inguinal ligament. That is quite important to know. That's sort of like a landmark for the deep ring. And it's really, really, really important to know that it's lateral to the epigastric vessels. So this red line here is the inferior epigastric vessels that you should remember in the lateral umbilical ligament. So please remember that. Yeah, so just know it's lateral. Whereas the superficial ring is kind of closer to the pubic tubercle. And you don't really have to know what it's made out of, but if you do, you're welcome to. So it's really important to know the contents of the inguinal canal. So in men and women, there's a few differences, but they both have an ilioinguinal nerve and a genital branch of the genitofemoral nerve. Okay, very, very important. Now the male has a spermatic cord and the female has a round ligament. Yeah, just know that for now. I'll be talking a bit about that maybe a bit later. Okay. Really, the only sort of examinable question here is that during a hernia repair surgery. So again, hernia, just remember that that's something protruding through somewhere that it shouldn't be. So in this case, in inguinal hernias, you have a bit of your intestine actually protruding through your inguinal canal, essentially. So we need to go and repair that sometimes. And during surgery, the ilioinguinal nerve is most at risk of damage. And ilioinguinal nerve provides sensory innervation to a bunch of areas. Honestly, just know that it's a sensory nerve. You don't really need to know much more about it. And just know that the inguinal nerve doesn't actually travel through the full canal. It sort of enters like midway. So it doesn't, as opposed to like the genitofemoral nerve, which does run all the way through the canal. Yeah, and then the only other important thing is the genital branch of the genitofemoral nerve is a motor nerve, and it provides motor innervation to the cremaster muscle in males. And we'll talk about the cremaster muscle reflex in just a second, so we'll revisit that. We have something called Hasselbalch's triangle, and this is really important. This is really high yield. Hernias in general are very high yield. Please know them like back to front, honestly. So Hasselbalch's triangle, so if we look at this picture here, these are the inferior epigastric vessels here, this line here. The green one is your rectus abdominis, and the yellow line is the inguinal ligament. So you can see together they make a little bit of a triangle. So just know that this is the lateral side of the person and this is the medial side. It can be a bit confusing. So just know the borders. If you can draw it out, a lot of these borders, I recommend not just rote learning it, like drawing it out. It makes a bit more sense, a bit easier to learn it. So we have two types of hernias. We have a direct inguinal hernia and we have an indirect inguinal hernia, and all a little bit different. So in a direct inguinal hernia, we call it direct because it goes straight through, directly through Hasselbalch's triangle. And why this is a thing is because the Hasselbalch's triangle is an area of weakness in the anterior abdominal wall. So it's pretty easy for intestine to just herniate straight through it. Now, you can see I've written here DIM, directed medial. So all I mean by that is that a direct hernia is going to be more medial to the inferior epigastric vessels, whereas an indirect will be lateral. Okay, that's essentially all you need to know about that. And how you remember it is DIM, direct is medial. That will really make your life a lot easier. So talking about hernias, as I said before, there's indirect or direct. Indirect is the most common one. It's 80% of all inguinal hernias. So an indirect hernia is the intestine goes through the deep ring and out through the superficial ring. So if we go to, oh wait, actually I think that, there we go. You can see here the intestine is going through the deep ring all the way into the superficial ring. Okay. Wait, sorry, indirect. Sorry, ignore what I just said. Indirect is going through the deep ring. I was like, that doesn't look like a deep ring to me. Yeah, so indirect is going through the deep ring and all the way out through the superficial ring. And remember, so in the direct one, it doesn't go through the deep ring. It goes through Hasselbalch's triangle, which is an area of weakness. So saying here defect in the posterior wall is talking about Hasselbalch's triangle. And both of them can exit out the superficial ring because it's sort of like area of least resistance. It just travels down. So indirect inguinal hernia is an embryological defect of incomplete closure of the processus vaginalis. Don't get too overwhelmed about that right now. I'll cover what that is in a few seconds. And herniates through the deep ring. Whereas the direct one is an acquired inguinal hernia, meaning that it's not embryological. There's weakness in the Hasselbalch's triangle and herniates through that, essentially. And that weakness must be weakness in the posterior wall, or you have a lot of intra-abdominal pressure in your abdomen that's forcing the contacts through the already slightly weak area of Hasselbalch's triangle. Yeah, so that's important. It presents with a lump in the groin that minimizes when lying down or with minimal pressure, and there's a bit of a discomfort. Sometimes it's asymptomatic. It just depends. And sometimes we need surgery, sometimes we don't. It just depends. So how we clinically differentiate between a direct and indirect inguinal hernia, if you press down on the deep ring, which you should remember is the midpoint, above the midpoint of the inguinal ligament, that's why it's important to know. Press down on the deep ring and the hernia is still there, it's a direct hernia, okay? Sometimes, I know last year would have covered femoral hernias. Sometimes they present a little bit similarly. Essentially, inguinal is a little bit higher, femoral is a little bit lower, okay? That's essentially all you really need to know about that. But yeah, please make sure you know this slide inside and out because very, very high yield. So as I mentioned a little bit earlier, I'll be talking about the cremasteric reflex. So remember the cremasteric nerve supplies, the genitofemoral nerve supplies muscle innervation to the cremaster muscles in men. And so men have this reflex when the inner thigh is straight, the ipsilateral testicle will rise due to contraction of the cremaster muscle. Okay, so ipsilateral just means the same side. Okay, so if you stroke the right side, it's the right one that will rise. Whereas contralateral would mean the opposite side. So just so you're aware of what that means. Honestly, don't really need to know the afferent efferent limbs. That's just for your information. But if there's no cremasteric reflex, there's three things that it could be. It could be testicular torsion, where we'll be talking about this in, again, a few seconds. But that's essentially your spermatic cord sort of twists. It can be an upper or lower motor neuron lesion. So essentially your nerves are just not working somewhere, either in your brain, your spine, lower down, who knows, or in a hernia repair due to the ilioinguinal nerve being cut. Don't ask me why specifically is the ilioinguinal nerve. I don't fully understand it myself, but apparently it is specifically that. Don't think it's very high yield, but that is a common thing after surgery. If they're not having cremasteric reflex, you're thinking, oh no, I've done something wrong. So we're going to be talking in general about the scrotum, the testes and the descent. I remember when I was learning this last year, I was so confused. Why are we talking about testicles when we're talking about like the stomach and the abdomen? And that's because the testicles, they start off in the abdomen and then they descend down and they descend past the abdomen into the scrotum, essentially, okay? Which I guess is sort of like an extension of the abdomen. That's why we talk about it, okay? So descent of the testes. So essentially, we'll look at this diagram here. It's a very nice diagram, I think. You can see here we have the abdominal layers and we have the scrotal layers, and you'll see that they're very, very similar. They're actually the same, except the transversus abdominis doesn't exist in the scrotum, okay? Because it starts off in the abdomen and it goes through all of these layers, apart from the transversus abdominis, and sort of herniates out into the scrotum. So when the testicle descends through here, you can kind of see all these circles have been drawn through the deep ring and the superficial ring of the inguinal canal. It herniates down and brings all these layers with it, okay? So if we have a look from all these layers, the testicle has the tunica vaginalis, which is actually peritoneum, okay? So most inner layer of the abdomen, and it's the peritoneum, and it's coming back inside. And so we have a double layer of peritoneum that's actually in front or more anterior to the testicle. And that's why we actually have parietal and visceral peritoneum, which comes from your parietal and visceral peritoneum in the abdomen, which we'll be talking a lot more about next week. And so the testes are actually pulled by something called the gubernaculum, which actually pulls it all the way from here, and is essentially like a ligament. It just pulls it back down all the way here. And in adults, the gubernaculum becomes a scrotal ligament. Yeah. And so essentially, as the peritoneum and testes are descending down, it takes all the other layers with it. Just the exception of the transversus abdominis. I know I keep saying that, but it is important. So you can kind of, it's good to actually be able to draw this diagram. It's very, very helpful. I think, yeah, I have this summary slide. You can see like the peritoneum in the scrotum is a tunica vaginalis. The transversalis fascia becomes the internal schematic fascia. So just have a look through in your own time. Take this slide and take this picture. Make sure you understand it and potentially draw it. I think that will really, really help you. So you can just see all these different layers. Again, go through it in your own time, but it is very important. Yeah. So we're going to talk about ectopic testes and cryptorchidism. So sometimes, you know, you might have a child born and they might be missing one of their testes. So a variety of things could have happened. Either there's an ectopic testis or there's cryptorchidism. So ectopic testis, you can see here on the left side of the image, or on the patient's right, you can sort of see the general structure of where the testis should be moving down. So it starts off in the abdomen, goes through the inguinal canal, here's ended up suprascrotal, and it should end up a little bit lower. So you can see it's going down like this. Sometimes it doesn't do that. It doesn't descend properly. So it might be stuck in the abdomen, didn't even move down into the inguinal canal, or it might get stuck in the inguinal canal. That's called cryptorchidism, which is essentially an undescended testis. It didn't go all the way down. Okay. Often they'll actually just later sort of move down. Sometimes they won't, which becomes a little bit of a problem. An ectopic testis is very similar, but instead of just being stuck along the way down, it actually moves away from the path completely. So you can see here, we've ended up with a testis essentially in the leg, okay? Or here, that's above the penis, okay? So ectopic testis has just moved completely away. And these people, this won't just spontaneously resolve. They might need help. Now, why this is actually really not good is because there's a reason why the testes are outside the body. That's because they need to be kept at a cooler temperature than the rest of the body so that sperm can develop. So if you have a young adult male come in and you realize they're missing a testis, and apparently that actually happens quite often because these people don't necessarily, no one gets checked to see if there's two. So sometimes you will get an adult come in, never having properly realized that they only have one testicle or maybe even no testicles. You have to straight away look where it is, and you really have to closely monitor it for testicular cancer infertility, because if it's stuck inside the abdomen, there's a lot more heat. And that can essentially destroy the sperm. So it's really, really not good, and you might need to get it surgically removed. Yeah, so please, please, please learn this slide, very, very important. Next, we're going to talk about varicocele and hydroceles. So essentially, if we go back to this part here, sometimes in your tunica vaginalis, you might get a bit of fluid accumulation, okay? That's called a hydrocele. So when you have a hydrocele, and go back to the slide, you can shine a torch at the testicle and it'll kind of like shine through. It's very random. I don't know who decided to go shining torches down there, but we do. And so it transilluminates, it lets light through because there's fluid. And as you can kind of think about it, if it's not tissue, it's fluid, it's going to let the light through. And people will present with sort of a pain with swelling because there's fluid accumulation there. A varicocele is also quite similar. It's also, I guess, like a bit of swelling down there, but it's not due to fluid accumulating in the tunica vaginalis. It's actually, there's a bit of venous congestion in the veins of the scrotum, essentially, and specifically of your pempiniform plexus. We might talk a bit more about that later. And it's described as having, like the testis is described as having a bag of worms feeling on palpation. Again, I kind of hate that, but that's how they described it. And that is like both of these bag of worms and the translumination is very much buzzwords, so please learn them. And this is actually much more common on the left side because the left spermatic vein inserts at a 90-degree angle into the left renal vein. There's more chance for obstruction. So a lot easier to see it on the diagram. So we see here we have the left renal, the left vein here, testicular vein, inserting into the left renal vein. I know you haven't done this yet, but it makes sense. You can see there's a really sharp 90-degree angle, whereas the right one just very smoothly inserts into the inferior vena cava. And so there's less chance for anything to sort of get stuck and obstructed on the inside. That's why your left is much, much more commonly affected, because there's just more chance for a bit of problems getting the venous blood through. That's why I get it very costly. Yeah, and this one will not transluminate because it's not really like fluid, it's like blood going through. Testicular torsion. Testicular torsion, as I briefly mentioned, is essentially when the spermatic cord twists, and the spermatic cord carries your blood and your neurovasculature. So essentially, if you twist the spermatic cord of the testes, you're putting the testes at risk of ischemia and infarction. So essentially, they just die off, which is really bad. That's why this is like you need to be able to know this and treat this ASAP. So typically, people will present with sudden onset unilateral testicular pain, and it's generally apparently really, really excruciating. You will probably know they have testicular torsion. These people also have an absent premasteric reflex. The testis will be very swollen. And you can see here on the right side, this picture here, I have a bit of a diagram. So this is a normal spermatic cord untwisted. You can see here, spermatic cord is really twisted on itself, okay? And that's why you get really swollen testis. They're generally nauseated and vomiting just from the pain. Now, with a bell clapper deformity, this is related because you can see here in the normal one in the upper picture, the spermatic cord it's like attached sort of to the top right of this picture. Okay, it's not too far posterior, it's not too superior. Yeah, it's right there. Whereas with a bell clapper deformity, the spermatic cord affixes right to the very top of it, and because of that there's just higher mobility of testis. Because there's higher mobility, it's more likely to curl on itself, causing torsion. So you want to be aware that these patients are more at risk of this medical emergency. So then there's also the posterior abdominal wall. I will not be covering this. This honestly is very low yield. Just check it out in your own time, to be honest. This is also very low yield, but it has been mentioned. So we have something called the lumbar/petite triangle. It's sort of on the posterior lateral side. There's just some few muscles that make this. Why we care about this is because it's a site where hernias, again, can also occur, but it's not very common. Okay, and that's it. I really doubt you need to even bother learning the borders. Just know that it's a site of possible herniation. Now, I think this is one of my last slide, almost there. So you'll learn about different types of abdominal surgical incisions. I thought this was really fun what we learned about. I was like, oh, it's exciting. So I'll go through all of them. So we have a midline incision, which is essentially what it sounds like. It's just straight down the middle. Okay, so you can see number 2 here, it's middle. So this will make more sense when you learn about all the other organs and where they all are, which is why your quadrants as well, if you can start learning them, that's really helpful. Midline, you're doing it for a AAA, which is an abdominal aortic aneurysm, which is where your abdominal aorta is essentially really like bulging out and wanting to explode, and it really is very, very bad. Yeah, so that's why you do a midline. And also midline gives us a lot of opportunity to see a lot of the abdomen. Okay, you really get to see all of the anatomy when you're doing a midline incision. Okay, but we don't like doing it because you can imagine such a major incision is very poor healing, and you can imagine when the patient sits up, it causes a lot of discomfort for them when sitting because they're essentially just folding their incision in half, and that's a bit ouch, so we don't want to do it. Transverse is kind of the opposite. It's a horizontal incision, so it's number 7 on the diagram here. Transverse incisions are good because they actually really strongly heal, because it's easy to actually sew up in all the layers. So you go in sewing up through all the fascia, all the muscles, all the skin. It's just a very, very strong incision. And as you can imagine, like, the patient can comfortably sit up after a transverse incision compared to a midline. But what's not so good about a midline is if you go too high up or too low down, you might miss the pathology that you're looking for, which is not so good. And then we also have a steeple incision. So I don't think, there's not a steeple incision on the diagram, but essentially it's, if you look at number 1, that's a kosher incision, you'd have one on the other side as well, and that's a steeple incision. Only time you use that is for a liver transplant. And a kosher incision is just on the patient's right side, and that's just for the gallbladder removal or having a look at the gallbladder and stuff like that. Paramedian, kind of what it sounds like, it's just on either side, so it's number 6 here. Again, it has a bit of stronger healing. I'm not too sure why, but it just does. And Pathantio is for gynecological surgery. It's just at the bottom here, number 9. I don't think it's too high up, but I have seen, I think, 1 exam question, so it is interesting to just know. I think this is the last slide of our presentation today, so we've got through it. So I just quickly mention the Transpyloric Plane. We might come back to it next week, but just so you can start getting this into your head right now, the Transpyloric Plane is essentially an axial plane. If you were to cut someone in half through the L1 vertebra and the 9th rib, you'll see a lot of these organs. And it's just really helpful when you're doing imaging in particular and you're trying to figure out what everything is. You know that you above the L1 or below the L1, you know what you're sort of looking for. So we'll probably go through this more next time, I reckon, when it makes a bit more sense. But you can start having a look at what all these organs are. Most important to know is that it's an axial plane through L1 and the 9th rib. Sometimes people just memorize L1 vertebra without realizing that's also 9th rib, and they get a bit unstuck on that. I don't have like a fun mnemonic for this, unfortunately. You can have a go trying to do it on your own. But yeah, this is just something you're gonna have to memorize. The more you see it, the more it'll get into your head, and we'll probably cover this a bit more in detail once you know what the funness of the gallbladder and the neck of a pancreas is. All right, so I think that's it. I'll save all the questions for our next presentation. So again, if you have any questions, just let me know. You can message me on Facebook or send me an email or whatever. And join us next time for some fun questions. Thank you very much, everyone.